Right, are we on? Hello, everyone. Good morning. So welcome to this event on patient-centered care. This is part of the TechNExt Festival. So that's the celebration of the Northeast technology sector. We're here in the room at the Opencast office in Newcastle and online. So thank you, Opencast, for hosting today. We've got a really interesting audience for this. So looking down the list, I saw there's people from NHS, healthcare providers, tech industry, universities. So I was really pleased to see that really interesting mix of roles for this, and across medics and non-medics. So thank you everyone for coming, and you're very welcome today. I'm your host. So I'm Andrew Besford. I'm a non-exec director at Northumbria Healthcare. So that's an acute NHS trust. For anyone that doesn't know the region, that's what covers Northumberland and North Tyneside. So it's a population of about 500,000 people. Because I'm hosting, I have the honour of telling you where the toilets are, which is over there. and also, can you guess what comes next? We're not expecting a fire alarm, but if it does sound, the fire exit is behind you there or through the reception, and you need to gather at Cake Stories. So there's a bit of an opportunity there as well, I think, if the fire alarm goes off. And if you're online, then that's your chance to put the kettle on. Also, if you're online, if you need captions, then you can press the show captions button. And so that, that should bring up captions for you. And we're encouraging questions today. So we'll keep plenty of time at the end for questions. We've had a few good ones in advance, so thank you for those. And if you're online, then please ask questions in the chat throughout the session. And Ellen's going to pick those up and bring those to us at the end. And we've got microphones in the room for anyone who'd like to ask who's in here. So we're on until 12. And then after that, there's some lunch and opportunity to meet people in the room. And then there's also an afternoon session in here, which is on unlocking the power of data. So I think that could be of interest to a similar audience. So you might be keen to stay for that if you can. I think just sort of last of the reminders bit is, so we're in the pre-election period, obviously. So this event was organised before the election was called. And obviously this isn't the forum where anything was going to be announced or anything like that. But I'm just reminding everyone that some of us here are going to need to avoid saying anything that could be contentious or influential. So if we could respect that, please, just as we're going through. So thank you for that. So with all of that done, going to introduce our panel. So, so let's start with Uta. So Uta Schauberger, Uta leads a design course as part of the University of Edinburgh's Master's Programme on on design in health. And Uta leads the service design practice here at Opencast and is also working as a service designer at NHS England. So welcome, Uta. Right, so you're a designer. So could you start us off by just giving us a quick view on what patient-centered care means and what the role of design is in that?
Yes, absolutely. Well, patient-centered care means a lot of different things. And of course, one of the key elements is the clinical practice around that. But I'll leave that to the clinicians in the room, and that is not what I work on as a service designer. But there's a whole other element to the NHS, and it is in the title, it's the National Health Service. So a lot of the challenges in the system that we see now are actually about those service elements. So the steps that repeat throughout the system, whether that's a hospital or a GP, cardiology, orthopedics, there's these almost plumbing elements, if you will, the boring parts like booking appointments and arranging things and just repeating tasks that both patients and staff have to do to organize care and to make sure people can see the clinicians they need to see and get the care they need. And those are a service, and it's really what designers do and what technology can help a lot with. So the organization of care and making sure that's accessible and easy to navigate for patients and staff, that's the part where service design comes in. So very different from the clinical practice side of things.
Great, thank you for that. And we will go into that some more. So as you mentioned the clinical side, I'm going to go to Murray next. So Murray trained in emergency medicine and is a GP partner in London and is also co-founder and chief executive of a company called eConsult. So welcome, Murray. And so your tech company's focused on digital triage.
Yeah.
So could you just explain a bit about some of like what you were setting out to do with that, some of the challenges that it is looking to address?
Sure. So firstly, thank you very much for having me on the panel. It's very exciting to be here talking about this. So clearly, I've been a doctor for 25 years now. So, you know, and actually we're trained at medical school to put patients at the center of everything. We built eConsult mainly because we were frustrated with the patient's lack of ability to book an appointment with us as GPs. So actually, we recognized how hard it was for patients to come in and see us. And also, you know, actually, why make people get on the phone at 8 o'clock in the morning, wait in a queue for an appointment, and then you have to come into a building for something relatively simple that you probably didn't need to come into the building to have sorted. So that was really the driver for us to get into technology. It was kind of like, how can we harness technology to make this better for our patients? And so built a platform that allows patients to go online and have a lot of their healthcare needs addressed digitally, clearly bringing patients into a building when they need to be brought into a building. But in the old world, you know, everyone just got 10 minutes in front of a GP, whether you needed it or not. So that was the kind of idea we set out to address, and that's now been adopted across, actually, in theory, every practice in the country should have some kind of online access. There's another kind of side of this debate about how well practices use this technology, but that's another story. So yeah,
Great.
I spend most of my life now running a tech business, and I'm still a bit being a GP, which is really interesting and helpful.
Great. Well, thank you for being here. And last but not least, Jamie. So Jamie Whysall leads the health practice at Netcompany. Netcompany's a Danish digital transformation company. I think that's interesting because Denmark was ranked #1 again in the United Nations e-government survey again. UK is now down at 11 in that. So could you maybe say a little bit about some of the interesting things you're working on in Denmark and a little bit about kind of how you're looking to bring that to the UK?
Yeah, sure, no problem, thank you. Yes, so Netcompany has been responsible for about 60 to 70% of the digitisation in Denmark. That's led to them being top of the UN rankings. So we work across the whole of public sector in Denmark, so from central government right the way through to health and social care, and have a very broad range of experiences in integrating systems together and providing the linkages around data, which I think is the key kind of foundational stone to being able to be patient-centred. In the UK, we are building out on those foundations, trying to take some of the lessons and some of the technology that we've deployed in Denmark and bringing that to the UK market. Probably the biggest example of that we've done so far is lifting the COVID pass solution from Denmark and deploying that in England and in Scotland in support of the pandemic a couple of years ago.
Great. Okay, well, welcome everyone. Thank you for being here. So I wondered if we should start, if we're here to focus on patient-centred care, I wondered if we should start on whether we really have a shared understanding of what that means. And I guess I'm picking up in particular on what Murray said about everyone's taught at medical school to put patients at the centre. So why do we think this is something we should be focusing on? Who'd like to dive in on that?
Yes. There's so much in that question. Yeah, absolutely. So I suppose an additional part to my introduction is that I'm also disabled, and I have a lot of experience navigating different healthcare systems in different countries. And based on that experience, I would very much say patient-centered care matters. And it is, like Murray said, about making sure that all these different systems, so both on the data side, but also that front end that Murray was talking about, work together so that people can get the care they need and can get in front of a clinician when they need to, or fill their needs in other ways. Because, well, you know, I think especially in the UK, this is a public service, so we need to make sure it works for everyone. But the reality is also that for the NHS, for an organization running a healthcare service, it is actually cheaper and easier to run a good service that works for everyone. So there really isn't any excuses why not to do that. There aren't any good reasons for it. But I'm interested in what you're saying about a shared definition, because I find as a designer, there can be a bit of a culture clash between, well, design, technology, clinical practice, and all these different professions that work in healthcare and that try and organize it better and improve it at the moment. But what often is also the case is that we have a common purpose, which is make it better and make sure it is patient-centered and people get what they need. And it's that conversation about the purpose where I see a lot of common ground and that really unites people. And it can lead to almost a healthy tension between all these professions and how they work differently. So, for example, clinicians can be very risk averse, and that's a good thing. I wouldn't want my clinicians to take lots of risks with my health. That's obviously the right thing to do. But in design and technology, we depend on a little bit of risk. We need to experiment, we're introducing new things, we're changing things. So of course, we try to make that process as safe as possible, and there's lots we can do in that respect. But still, there's quite a different culture between those two areas. And what is important to improve our collaboration is that shared purpose and that common definition of patient-centered care.
Yeah. You're reminding me a little bit of something Jamie said last week, which is about not calling it user-centered design in Denmark.
Yeah, I'll pick up on that point. So yeah, in Denmark, and we've had this interesting kind of dichotomy with our UK business and our Danish business as how they approach stuff. One of the things that we've noticed is that user-centered design in Denmark isn't referred to as that. It's referred to as equity by design, referring to the fact that users aren't the same, and that actually it's about designing services that work for individuals as opposed to an amorphous blob of a user, which is quite an interesting kind of concept when you think about that and applying that to products or to services or to end-to-end systems and pathways. Yeah,
and Murray, your product's about getting the right patient to the right clinician. So I think Uta's touched a little bit on some of the benefits that we're trying to get, but could you sort of fill out a bit around some of that? Like Uta talked about giving the right service to people and the potential sort of cost impacts. Could you talk a bit about some of the benefits of patient-centered care?
Yeah, for sure. And I totally agree. I think if you can get the right patient in front of the right clinician, there's going to be an inherent efficiency in doing that. I mean, we estimate about 30% of patients are sitting in the wrong queue for healthcare. They're either waiting to see a GP when they could be seeing a pharmacist, or waiting to see a dermatologist when actually it could be handled somewhere else. So I think there's a lot of people sitting in the wrong queue. So I think if you can use technology to support and fix that, then it's undoubtedly going to be helpful. I mean, I think that it's interesting, that kind of patient-centered, user-centered. We've, clearly as a clinician, you are putting the patient sat in front of you at the center of what you're trying to do. I think there's a tension which we've got to deal with, which is there's the clinician as a user as well. And certainly when you're thinking about technology, you can't just put the patient at the center, because if you go back to that example is the beginning of the kind of GP appointment booking, that's not a patient-centered design, right? We make it very hard for a patient to come in and see us, if we're honest, right? Waiting 4 weeks to go and see a GP for something is not a great user experience. But equally, you can't kind of, what the patient would like is the ability to interact with their GP, either in person, on the phone, or online at any time. Now, and we've got to ask ourselves, is that achievable within the NHS today? Now, we could definitely do better than we are doing, but I think we also, and we struggle with this, if I'm honest, at eConsult, because it's kind of like, to what extent, when we're designing technology, do we weigh the needs of the patient versus the needs of the clinician? Because you can't build a system that's entirely patient-centered, because your clinicians won't use it. Equally, if you build an entirely clinician-focused system, it's probably not very good for the patients. So you've kind of got to balance. It's a tricky balance to find.
Yeah.
So yeah.
On that, actually, one of the at the risk of jumping around, but one of the questions that was submitted in advance was about exactly that. So somebody wrote in that with so many systems that clinical colleagues use on a daily basis, how do you ensure you build systems that have a high adoption rate from both patients and the clinicians that support them without becoming yet another step in the patient care pathway? So I think you're touching on exactly that point there. And I don't know if any of the panel have got an idea about where that's been done really well, or where some examples of what good looks like for that. Jamie, go on.
Can I take an example of something that we're doing at the moment, which is precisely doing that in terms of creating a new system for both patients and clinicians. So the work that we're doing with NHS England around Register for GP, so taking the GP registration system from a disparate set of paper forms to a consistent national service. That is improving the system for patients. So 48% of registrations that we see through that system happen outside of GP working hours, so available to the patient when they need it. In contrast, it's saving typically 15 minutes within a GP surgery administering that paper form. So there's a win-win there. But in order to do that, what we had to do was actually go and look at what the root cause was. And the root cause and what led us towards that was actually there was a data quality issue in the national systems, that GP surgeries weren't able to match patients upon registration with the core data that's held by NHS England. But by looking holistically and going, well, actually, can we change can we flip the system and do this in a different way? Actually, we can bring benefits for both patients and clinicians and balance those two things together.
Interesting. Any other good examples you'd like to raise? We might touch on some as we go through.
I can build on Jamie's
Yeah.
example, actually, because so my role in NHS England at the moment is on a neighbouring project to the one you mentioned, as you will. And I think what's been interesting for me is looking at all the change that is happening to GP registration on its own and how positive that has been. But also it opens up new possibilities for for better data quality and more integrated services in other parts of the system. So you get that nice effect when you start in a corner, any corner almost in the NHS, because we all know it's a huge system. It's really challenging. It's really difficult to work with. And that can be overwhelming when you're trying to think about how do we get from now to patient-centered care. But the reality on the ground is once you start and you take a corner of it and improve it and do the great work Netcompany has been doing on that, it ripples through the system, and it opens up new opportunities for technology, for designers to work with clinicians and make it better for patients and staff. And I think that's really key to how we're trying to work as well.
So I think it's interesting you go into the sort of technology and the kind of and how many corners there are where that could help. So I wonder if we could go down that route a bit and talk about specifically what's the role of technology in improving the way some of those services work, and thinking about how that's part of a solution that includes all sorts of things like recruitment and the myriad of things that need to get done. So could we talk a bit about how clinicians and designers and technologists work together? I guess I'm asking that particularly thinking that some of the language, like this is quite a sort of digital focused event, some of the language that we use around service design and user research and that kind of thing is all very familiar to us, but maybe a little less so in the health system. So how do we collaborate better? Who'd like to go first? Go on, Murray.
Yeah, I don't mind. I mean, I think it's, I think the bit we've got to, I think everyone would agree, I think, that healthcare is one of the kind of last industries to properly embrace technology. Mm-hmm. So when you as all of us are patients, but actually we do a lot on our phones or on our devices in everything else, a lot more than we do in healthcare. Okay, so when you think about how technology has transformed banking, shopping, travel, all of those industries, healthcare is lagging for sure. Okay, and so I think so kind of logically you'd go, well, yes, we should apply the same kind of lessons we've learned from all these other industries in healthcare, but it's hard, right? Because actually it's difficult. There's lots of silos of data and lots of challenges around that. But and I'm an eternal optimist, so we will get there in the end. But I think the truth, the real truth here in the UK is if we want proper tech, we need to invest in it. And certainly the challenge, particularly over the last couple of years, I think, is a lot of investment in technology and healthcare has been kind of siphoned off and sidelined. So I think a lot of kind of pots of money being put forward to transform through technology, great headline, but actually for other reasons, that money hasn't been then deployed. So, the NHS doesn't really ever say how much of the budget is spent on tech, but it's about 2%, which when you judge it against other industries is tiny. So 2% of the overall NHS budget is spent on technology versus, 10% in something like banking. So that's the first thing we have to ask. Like, if we're really serious about using technology, why aren't we investing in it? And that's the kind of, I think I'm allowed to be maybe political in a way that you're not, Anna.
Crack on, yeah.
But I kind of think I'm glad there's an election coming. So I think we've got a bit stagnated and we need a bit of change, whichever direction it goes in. But we do need something needs to change, and we need an honest conversation about, well, if we're really serious about investing in technology, as we should be, we need to invest in technology and stop kind of just pouring all the money into people and hospitals.
I'll come to Uta and Jamie in a second on this, but it's interesting what you say about healthcare being one of the sort of later industries, if you like, to embrace tech. Because something that we've found in our hospitals is when we've got members of staff using a handheld device to manage the flow of people through the hospitals, the patients sort of assume they're watching TikTok videos. And we've had to, because there's almost an expectation that we haven't yet embraced this stuff. And we've actually had to put stickers on the back of devices saying, I am using this to do my job. Because I think it's sort of so unexpected. And we're making really good progress on that. But I think I really like Uta's reference to corners, because there are so many places and so many lids to lift. So I guess, should we stay on the sort of collaboration point a little bit? I don't know if Jamie or Uta would like to pick up next, but just on kind of how we get teams working together and how we kind of get into some of those corners and make solutions that work. Yeah, go ahead.
So I think from a tech perspective, there's been a historic focus, just to build on Murray's point, to point solutions in bits of the system. So be that in secondary care, in primary care. I think the conversation and where tech actually has the ability to have impact is in bringing those systems together, to the point of, we've got people that are waiting in queues, and it's not until you get to the front of that queue that we question whether they were in the right queue, and then they go into a different one. And I think that's the role that tech, there's an opportunity for tech to play, is in starting to understand where everyone is in that system, and making sure that they're on the right path based on the history of them, the history of people with similar conditions. Actually, with modern technology, that can, the data is there, it's all sat in systems. The data in the NHS has largely been digitized now, but what I would argue is it's not been digitalized in terms of them being able to leverage that to shift the system forward. And to, again, build on a point, we're talking here about patient-centered care. In any other industry, we'd be talking about customer experience, and as a system that people don't pay for directly at the point of care, actually that customer experience can be lost because a patient hasn't got the ability to walk away for the most part.
Yeah. And Uta, I guess something you're interested in is about the other users of the system. So how do we figure out the needs of, so we've mentioned healthcare professionals, but we've not mentioned families, we've not mentioned carers. What about that angle on things?
Yeah, that's such a good point, because overall patient-centered care isn't a challenge we can ever solve in silos, both on the tech collaboration side with clinicians, but also when it comes to the person. They're not a set of organs that walks through the door and is being done things like that. Of course, that's not the case, but also they have lives, they have families, they have friends. So there's a whole complexity to how we design care around that. And I think one analogy that an Opencast colleague used last week, actually, that I really liked was embroidery. So I don't know how familiar people are with embroidery, if not really.
You might need to
get
explain a
into
little.
I will explain. So if you look at the front side of embroidery, if you will, you usually see a beautiful pattern made out of different threads, an image, a symbol, whatever it is. But on the back, it's sort of chaotic. So if you turn it around and look at the back, it's loads of different threads going across, and you can't see what image it's actually trying to portray some of the time. It just looks really chaotic. And I think, interestingly, my colleague used this as an analogy for service designs. You've got this beautiful service at the front that people come and use, and it's really easy to navigate and simple. But it may mean that on the back, there's, I don't know, 10 organizations involved in delivering that and a whole complexity to it. And I think our issue in health and care is that too often we still design the other way around, the wrong way around, I would say, where we're almost briefed to make sure the back end is neat and tidy and simple. All our system, we basically design almost for our internal bureaucracy by accident, instead of, and then we basically say, well, patients will just have to navigate this somehow because they should take care of their health anyway. And staff, well, we can mandate them to use our systems, and we maybe provide some training and educate them, and off it goes. And that is just not the answer. Of course, first of all, it's not the right thing to do. But again, second, it doesn't work. Unfortunately, it is not cheaper to run a service like that. It is not easier, and it just causes more and more chaos and actually erodes the trust in our system as well. So it's just not a good solution, and we need to return to doing it the right way around and providing that easy, simple service to people and the staff that are providing care. That's what we're trying to underpin good clinical practice with our technology and our systems. And I think it's really important to keep in mind that other industries have been in that place, other government departments have been in that place, and the solution that works is design, and that's been proven over and over again. And I think in health and care, we don't quite have the same trust in that practice yet. We don't have the same respect for each other necessarily, and that's where we need to improve that collaboration and be really clear about the shared purpose of where we're trying to go, and have a healthy tension between our different cultures that actually leads to better outcomes.
It's interesting that the mantra that we used to have that you reminded me of in central government for this was doing the hard work to make it simple. I think that's your kind of embroidery example in a way. I wonder if it's worth talking about this a little bit more, because I wonder if it's sort of one of the barriers to getting on with some of this around, like what you said there, Ita, is a really sort of balanced description between the healthcare system and the sort of digital approaches and the ways of working that we've got. But I don't always see those sitting well together, because I see kind of digital people, I mean, I say this with love and affection, but digital people who are very well versed on things like, how you do a discovery, where you bring user research in, all the importance of all those things, sort of user-centered design approaches that are quite normal in some places now. And I think, so we've probably got an audience here who's got quite a strong understanding of that, but then I don't think that the people who are tasked with modernising how services work necessarily see all of those things. So they feel patient-centred and they've been brought up to be patient-centred, but then there's this almost sort of tension where the digital folk would go, no, that's not user-centred design. So I'd just like to get into that a little bit more about how you do those trade-offs. And it's a little bit like, I almost see in my mind the difference between when you do a sort of online, like a kind of digital view of the world, that's almost like, oh, I'm searching for information about a hospital and I find what I wanted. It's a very kind of online experience. And then the challenge I hear from medics is almost like, well, that's lovely, but what does that mean for the patient who's in the back of an ambulance screeching to a full corridor of patients? So how do we reconcile those things and kind of get the best of both worlds? I mean, Murray, you've been at the front line of all of that. So how does that feel to you?
Look, I think it's, and I've always got, you've got to take a kind of long term. So with my optimist hat on, I always take a slightly long-term view on this, because it's going to take time. And I think a good example of this is how technology actually we've gone backwards a bit in the world I'm in with triage into the GP, because when we first started, and we did spend a lot of time with patients and with doctors going, right, if we were going to introduce technology, how would we do it? And one of the kind of great things about technology is you can leave it on 24/7. So actually we left these digital triage systems on 24/7. So actually, if you've got a problem on a Sunday night, you think you need your GP, you can deposit your symptoms on a Sunday night and your GP will pick it up on Monday. And actually, as a patient, that's a much better experience because on a Monday morning at 8 o'clock in the morning, you might be on your way to work and actually it's not, you know, you can't do it. However, the reason we've kind of gone backwards a bit now because as this market has grown, other competitors have come into the field who have kind of spoken to the GPs in the room who've gone, yeah, the problem with this online stuff is it comes in 24/7 and it would be much easier if I could turn it off. So we've now got products, competitor products, and we started losing customers to products who allowed the GPs to turn the tech off, i.e. you can do an online consultation, but only between the hours of 8 and 10 in the morning. And so we've had to introduce these tools as well in order to compete. So now actually more of our customers have an online system that they turn off in the day. And that kind of really goes against that whole kind of patient-centered design principle that we started with. But we've had to do that in order to kind of, now I'm kind of seeing this as a kind of like, you know, this is a bump in the road and we'll get back to it. Because I think the whole point about tech is it should be enabling this 24/7 access to healthcare. And the idea of you trying to submit something to your GP, you know, it's the digital equivalent of ringing the practice and saying, sorry, we've got no appointments, please ring back tomorrow. If you then have to go back again tomorrow and try and do something online the next day, what's the point? I mean, we've kind of missed the whole point there. So I think, but I kind of see this as, you know, we're bringing, what we're trying to do is bring the patients and clinicians on this journey with us. And that's going to take time. So we've kind of got to recognize that you can't fix all this stuff with technology overnight. It just doesn't work. But
yeah,
it's an example.
And what about, so there's a few things that sort of sit underneath what you just said around like bringing the data together and patients accessing their own data and that kind of thing. So should we talk about that a bit? Are there any good examples where we've done that or any other things that will take time to learn about that?
So there's a couple of examples of systems that we've done in Denmark, where actually we've put citizen health records into the hands of patients. And that has driven significant improvements in perception of care, because not only do they have access to what was said, because, you know, generally, if someone is in a face-to-face consultation, by the time they walk out of it, they've forgotten maybe what was said, or, you know, depending on what was delivered, it might have been quite an overwhelming experience for them. Putting that information into their hands in Denmark in the case that, and we've done that across both the secondary care system there and the social care system, enables, one, the patient to be able to understand that, but also that information to then be shared back to the point Uta raised earlier, with other stakeholders that are involved in that patient. And so that the patient isn't having to relive that every time they go and see, you know, go to their employer, go to their relatives, go to their carers. Actually, they can provide access to the portal. That information being in one place, you know, reduces the burden of care on both the patient and on the other individuals around them.
Yeah, and something that patients often say, isn't it, that having to repeat the whole story at the start of every episode is incredibly difficult. And something else that you said before, Jamie, was around showing patients where they are in the journey. I think that was a Danish example as well.
Yeah, so that's similar to the patient. So that's within the in the social care system. I think the example that we're talking about there. Actually, you're kind of saying, well, these are the next steps. This is where you've been. This is where we think you're going. And I think as we move to trying to be more predictive around journeys that patients will go on, the ability to share that has a comforting factor for the patient, because they can see, right, I'm moving forward, even though I might be a bit frustrated as to where I'm at now and I'm having to wait for, you know, a period of time for the next appointment. I know that next appointment then unlocks XYZ for me, and they can kind of see that in black and white, as opposed to, you know, imagining what might be next, which I think is the situation that most patients are in at the moment.
And it's interesting on seeing letters, isn't it? Because there's almost different bits of the system are catching up with the digital nature of that at a different rate. So something that I'm hearing more from clinicians is they might have had some care in hospital and a letter's been sent to the GP and the patient's seen it through the NHS app before the GP's seen it, maybe don't understand, maybe worrying content, could be anything in there. And we're starting to find these things running at a different pace now, where there's an awful lot to do to catch up with how that works.
Yeah.
So interesting. I'm conscious we've been talking for a while. There was one thing I wanted to cover in particular, which we might just touch on now, but if you start thinking of some questions and we'll get people involved in the conversation, I just wanted to touch on the sort of health inequalities angle of this and how patient-centered care can help reduce the inequity in the system. And I know, Uta, you're really interested in how we design for everyone and make services inclusive. So could we just explore that a bit?
Yeah, absolutely. So especially when we talk about technology a lot and digital, that throws up a lot of questions around equality usually and equity, as you said, Jamie. Also, it's really interesting that it's called equity or design. Equity by design. I will remember that. But I think what's important to remember is that there unfortunately isn't a magic channel. And channel is very much service design jargon here. So one single equitable way to deliver care every time. And it means that digital exclusion is a huge problem we're looking at. But on the other side, the way things work now, or even offering physical in-person appointments to everyone also isn't all that accessible for a huge range of people, or making a phone call or pestering the NHS for things, you know, that is also not the solution. And I think that's really important. And we do have a level of answer in that we have experts at designing these journeys right every time. So there's a process to that, there's a profession for that, and really a proven track record of getting that right, or at least more right than it is at the moment. But I think I'm always interested in these debates, because as someone who tends to work in digital, I get a lot of pushback from the equity angle of, well, digital exclusion is a big problem. We can't just digitize everything, and that will be really problematic. And I agree, but the answer is also not to leave everything as an in-person interaction. That is also not equitable. So it's really about doing the hard work of fixing our plumbing and making sure it works together, and there's different options for different people, and that it integrates and works well in that specific situation. So yeah, that's a very, it depends kind of answer.
Yeah.
But I think it's just not that easy. We don't have the magic equitable channel we implement every time and off we go.
Yeah.
And that's really important to remember.
And Murray, does that chime with the digital services that you've been creating?
Yeah, for sure. So I think it's so we've been on this eConsult journey for about 10 years now, and I'm getting less of it now, but certainly in the early days, a lot of kind of challenge was thrown at us saying, you know, okay, but what about the digitally excluded? And almost services weren't commissioned because of worries about, well, if you're digitizing this, then, you know, you're excluding X percent of the population. You know, it's a fair challenge, but to Uta's point, the old system wasn't particularly equitable. You know, actually before we used to channel everyone through the phone at 8 o'clock in the morning, you know, and it was fastest finger first. You know, how is that fair or equitable? So, and what we found in practices, and I would say, you know, big shout out to the Northeast, because we've got 300 practices in the Northeast use eConsult. They're one of the early adopters and one of the best adopters of this sort of technology. Actually, if you shift your digitally adept patients online, it frees up your phone lines. So to you know, to the point about channels, you need to offer online and phone and face-to-face. And actually, the patients who you find struggle with online were actually the same patients who struggle on the phone. So if you make phone access easier for those patients, they can now get through. Now, behind the scenes, there's ways of then capturing those people and putting them in the same digital queue for the clinician. But actually, it should be about choice for the patient of which channel they want to come in on. And that's, so actually, I'd argue that bringing in digital helps with that, you know, inclusivity, ultimately, if you do it right.
Yeah, good to see some nodding on that. And something that we've been experimenting with was, if you send someone a letter digitally and you can tell that they haven't clicked on it, then you print it and post it to them. And we're kind of really feeling our way around that and making sure that things don't get lost that way. I think there's probably hundreds of things like that we need to get our heads around, and a whole new set of best practices to emerge from it. So I'm going to throw it open for questions in that case, because we've talked about an awful lot there and probably could have talked about an awful lot more. So I'm not sure if we have, we'll pick up a couple in the room and then we'll pick up a couple from the online chat. If someone could give me a wave on whether we've got online ones. We've got, I can see Case, and there was another hand. Yeah.
Thank you, guys. And really, really interesting. I think I'm really interested in the sort of size and shape of the population that you try and collaborate, design for, because I think I've been Wikipediaing, and Denmark's population is 5.9 million. And so the Northeast, for example, is 2 million, not a completely different order of magnitude. But we often try and see in the UK that we might try and solve things on a whole UK or a whole England level, which is very interesting, right? Because it kind of sometimes makes the problems harder than they need to be. And I think the other part of that is that you don't necessarily have the context of that local landscape. So things like hospices, things like the care kind of infrastructure, that's quite local. And also populations are very different. So Northumberland is very dispersed versus London or whatever. So yeah, I'm just interested in that sort of experience of like, if you then think about the spend and how is the spend on technology funneled? Yeah, what are the sort of things that would make sense to be done nationally versus the things that would make sense to be willing to try to maybe fail, sort of fail faster, or try new things more regionally? And is there an opportunity in the Northeast to kind of get around that idea regionally so that we can solve some of these things in a way that isn't dependent on waiting for the centre to fix it for us?
Who'd like to comment on that? That's a big question around the structure of the NHS and the kind of how much is done by the centre and how much is done by providers. Go on, Jamie. Yeah.
Shall I respond with kind of the Denmark view? And I think the big difference, and I'm still kind of exploring my way around what Denmark looks like and how they work, but in effect, they are actually quite a regionalised model. So whilst a lot of it is driven out nationally, I think there's something like 12 health authorities that are split across the country that are not that dissimilar from what we would call an ICS, but clearly with a much smaller population footprint than we would have. And I think actually what we see there is that those health authorities then cluster, and so you start do I call it the market? The customers organizations kind of self-group. So there's certain things that will be done by an individual district, but then equally there are naturally things that might take 3 or 4 of them, and we've done an EPR deployment, and I think 6 of them have bought it together, and then the other 6 have bought a different one together. So nationally there's kind of a direction, but most of the operational activity is done at a regional level, and such like. I think there's a role for every, there's certainly things that need to be done nationally where you generally want to pull the population data together, and you need to, in order to then be able to go, well, this is what the population looks like, this is what the population needs, and this is something that is core, like GP registration should be consistent. But actually the agility in the system really needs to come at the local level, I think. And what is that optimum local level probably is different on a case-by-case basis.
I think that's quite fine-grained as well, isn't it? Because the local level, so we're in the Northeast, talk about the Northeast, it's interesting in primary care. So, there's a lot more small independent decision-making going on there. Murray's already touched on that aspect of it, and having 300 practices that are using your product. I think when you get into sort of hospital acute sort of setting, I mean, certainly, for the trust that I work for, it's different in the urban areas around close to here, around Wallsend and out to the coast, is different from up the coast, is different from into rural Northumberland. And it's really nuanced what different people will react well to or badly to on that area. So you might have people who aren't necessarily digitally excluded, but actually really struggle to get good connection at home, and all, it's very, very nuanced. So I think having any sort of blanket mandate around these things has been really difficult. And I think that means that the local systems are all having to sort of build their understanding. And we've done a load of work on sort of mapping this to like who've we managed to get online, who, you know, how many times we managed to save them having to drive somewhere. So I forget what percentage of the traffic in Northumberland we're responsible for, but it was quite a measurable percentage. And we started tracking at the start of COVID how many, we call it miles less traveled, which I'm not sure is particularly grammatically correct, but how many miles we've saved people from driving by being able to do things online. And we just kept that count going. I think it's just gone over about 8 million miles of driving around Northumberland that we've saved from doing online consultations. And it chimes with Murray's point before, and Lisa said this as well, around, you know, if we were doing things not at all online before, and then at the start of COVID, flipped to doing all sorts of things online or trying to, the truth lies somewhere in between. And I think we're still feeling for what that is. So that's not too much of a hand wavy answer to your question, Kate. Yeah, I'll repeat that for the folk online because they might not have heard you, but we might learn from that Denmark's quite a national approach, and here we're taking more of a kind of, you know, we've got the country, we've had quite an England-centric conversation here as well, haven't we, but carved up in a certain way. And I'll take the next question from over here.
Hi there, Murray, to your point about the kind of switching the system off, the consultation system off, and that to me kind of speaks of like mindset challenges and kind of adoption issues. I was just wondering, on the flip side of that, have you seen any work that you've done where you have seen that kind of real embracing of an adoption of the mindsets needed for the tech to really serve patients?
Yeah, no.
Sorry.
It's a really good question. I mean, I think certainly we have, and particularly I'll come and talk about what we've done in A&E. I think the challenge we've had in general practice is that, and this is true in the Northeast as well, so those 300 practices, some use online consultation really well and patients see it as a useful front door into the practice. Many don't. And that's part of the problem. You know, we haven't, as a region, as a nation, kind of thought about, well, how are we going to drive this change through so that actually this top tech does get adopted and is found to be useful. So, you know, and actually, if you're a patient and you try and use this system and it's switched off, you'll be like, well, that's crap, I'll go back and use the phone. Mm. So I think, you know, you have to think about that transformation journey that goes along with the technology. And in the way that we've procured these systems in bits of the NHS, we haven't done that well. The bit we've done it better in, I think, is in A&E. So we're doing a lot of digital triage in A&E now, where basically when you arrive at an A&E, instead of seeing a receptionist and then a triage nurse and then a clinician and repeating your story at various points in that journey, you check in on a digital tablet. So there's a whole bank of iPads. And the iPad asks you who you are and then why you're there. And it captures all that information right at the front door. And the benefit to the patient is you don't have to tell your story lots and lots of times through that journey. And you can also prioritize those patients who are really sick early on in that journey. Now, what's interesting is it's a kind of bit of a binary system. You've either got to have everything going through these iPads or you don't. And so actually the transformation bit, you have to take the A&E on a bit of a like few month journey of going, right, look, this is going to change, and get them all really bought into the idea, and they do. And actually often, you know, it then just goes much better because, you know, the whole team in that department are like, okay, on this day, we're going to change the way this works. And they're much more bought into it. And actually it does work. And actually you're going to get almost 90% utilization of the tech from day one. And that's really rewarding to see. And we haven't seen that in general practice. So I think there's lots of lessons to learn there about, you know, it is partly the tech, but it's also it's that bringing the users on that journey with you as you deploy that tech. And we're not very good at that as well, I think, as humans.
Right, I'm going to take one of the questions that was submitted in advance, and then maybe Ellen can shout out if there's any questions from online that we'd like to take. So one of the ones that came in advance was, what role do you see big data and personalized content playing in ensuring that patient experience is bespoke for every individual? And there's a bonus bit on the end, how can this be utilized to change behaviors in patients and support prevention initiatives? So quite a lot in that. Should we just tackle the big data personalized? So I picked up on that a little bit about personalized content, instantly made me think, I mean, obviously there's content in a lot of what we talked about, but that sounds like quite an online service kind of thing rather than a kind of, I'm in the back of an ambulance kind of thing. But yeah, what can we say about big data and personalization?
I mean, for me, it comes back a bit to the threads on the embroidery, the back of the embroidery, and we need to kind of just join some of these threads up, because I think the problem today is that a lot of this data all sits in lots of different silos, and there are things like the Great North Care Record, which are trying to bring it all together. You know, and there's a similar thing in London. But, you know, until we've got a good picture of that data, it's hard to then use it. So I'd love for the questions that we ask up front to be much more intelligent, because I know that this patient has diabetes and hypertension is on this medication, but I can't extract that data to ask that. So there does have to be a bit of kind of plumbing, a lot of plumbing, interconnecting all this data up and making it more accessible and available to the suppliers who then can make use of it, I think.
And I guess some of the benefits are even from data that's not that big by big data standards. So I know some people in our trust who've kind of gone through forensically everyone that didn't turn up for a colposcopy appointment and matched that up with everything and figured out how to work out who's not going to turn up and help them turn up. And that's, you know, as a technologist, you don't look at that and go, that's big data. You kind of go, well, actually, you could almost do that in Excel, but it's that join up. Yeah. So would anyone else like to talk about personalization or?
Yeah, I think I can talk about that a little bit, because especially big data, the thing that really stands out for me is patterns and learning over time, because in design, we can be guilty of reinventing the wheel a little bit, or every time looking at very individual challenges, if you will, and not having a better starting point to begin with. And I think for me, that's also quite interesting working with clinicians, because often their mindset and their practice is about this individual person because of patient-centered care, because of that training. So when we design services in collaboration with clinicians, we often focus a lot on the question of what is wrong with this person, if you will, medically speaking. Otherwise speaking, we're talking about behaviors as well in the second part of the question. And it gets so granular. And as a designer, I then find we've got this very long list of conditions and people with very specific circumstances to design for in order to cover everyone, if you will. And that is overwhelming, and it doesn't actually help that design process. It doesn't get us to good outcomes for everyone. And instead, thinking about the common barriers, if you will, to accessing care can be a much more productive conversation. So to give you an example, stairs. I'm disabled, I hate stairs, worst thing ever, but that's a separate conversation. But stairs can be really challenging for a variety of reasons. You're disabled like me and you can't get up them, terrible. You could have a pram with you, you can't get up them. You maybe have a broken leg and you can't get upstairs for 2 months without a lift. So it doesn't really matter in terms of the design of the service what the reason is for why you're not on board with stairs and you need that lift to be there, right? So basically, instead of focusing so much on almost diagnosing that patient when you're trying to design a service and going really granular to that individual level of, you know, how do we help people who have a broken leg? How do we support people who have this, who have this, who have that? And you can actually group the barriers of what people are struggling with, and then strategically try to avoid those or design those out, if that makes sense. So that's a little bit of a theoretical answer, but what I think the opportunity with big data is to spot these patterns and document them and work with them and really transform at a system level, while then using those in a way that is a starting point. So of course, you know, I've already talked about there is no magic channel, etc. And lots of the examples you mentioned, it is about patient-centered care and it is about the individual. But I think if we can lift our learning to a better starting point and then adapt services more from that already great place where we know a lot about the common barriers and how inclusion usually looks like and those proven patterns, it would be more efficient and more strategic, and it'll get us to that better stage of transformation faster. So I think that's where I see the balance, I suppose, between personalization, but also big data and learning at that level And I think that's a huge opportunity we've not quite looked at yet in detail in health.
That's good. Thanks. Thanks, Lisa. Right, Ellen, do we have questions that have come in online? Oh, okay. Okay, yeah, well, we'll invite any other last questions from online in the last few minutes. And I'll just pick up on, oh, we've got one more in the room over there. Sorry, I missed you there.
Sorry, I just want to take up all the time. Acutely aware that you guys have, by and large, focused a lot of the efforts around primary care and the first interaction with patient and the health service. And a lot of local authorities, I guess, have now been able to get this singular view of their customer. Do you think that the NHS in particular will ever stand a chance of having that single view of a patient from primary care into secondary care? And what would that take to get there?
Excellent. Who'd like to answer that then?
3 days.
I think actually patients
Ever's a long time. So I think
Yeah.
we'll one day.
I think there's areas where that's
Yeah.
starting to emerge. So there's starting to be good examples of things like in maternity care, where lots of different parts of the country are using the same system. And that means that if you happen to be on holiday when you go into labour, then your maternity notes can magically pop up in the place where you go into labour, which some people think that that's a miracle, and some people think that that's absolutely obvious that it should work like that, to the point where they don't even say, oh, well done for doing that. So, you know, I think that's some of the challenge we're up against. I think the sort of built into your question is a little bit about whether we should have a single place where all this is brought together, which I think is sort of very much a good debate to have about whether it should or could exist at all, even if we're kind of wanting to move in that way. I guess the question the question is sort of why, and that would be around, well, how do we make sure that there's a seamless journey across different parts of the system for patients if we flip it back into patient mode? So I don't know if you'd like to maybe focus on that end a little bit of it, if you'd like to comment.
I can actually give an example from Scotland, which similarly to Denmark has a population. Well, the NHS Scotland is actually roughly the size of NHS Yorkshire, to put that into an English context. So quite a different environment in that sense. But a couple of years ago, I was part of efforts to establish a national digital platform, which should be that central care record that is integrated and provides a central place for data, and then is trying to deliver that data to the right place at the right time for clinicians who have access, but also only have access to what you really need to provide care, etc. And it was a really interesting project, really interesting ambition. It's also still going, so look it up if if you have a chance. But what at the time, first of all, of course, the big challenge is all the different systems that exist in the digital space and integrating with that, etc., etc. But actually, the question on should we even do this, or what parts are actually useful and actually worth doing, how will it change care, and what are the new possibilities we're opening with this, was the more interesting one for me. And I think, again, there isn't a clear answer necessarily. And I think as we have more and more possibilities, it comes back to that common purpose of patient-centered care and really working in collaboration. So designers, technologists, clinicians, and I think also patients need a seat at that table, as well as social care and all the other parts of the health system we haven't mentioned too much today, to find the answers to those questions, or to define them, because they're probably about how we want to live, how we want to care, and how we want to organize care for each other. So there isn't a right or wrong answer. It is about defining the direction everyone wants to go in as a society as well. So yeah, really, really good framing of that question.
So bearing in mind it's 2 minutes to 12, I thought we could finish with something really snappy from each of you. Like what is the one thing that you'd like people to take away from this conversation, something that could be actionable that they could take forward? Usa.
That's an easy question to end on. 2 minutes. I think
2 minutes
collaboration.
between you, by the way.
I know.
And we're between all these people and their lunch, so.
Well, my one word answer is absolutely collaboration. We still work in silos, and we still have challenges between the professions we need to improve health and care and to make patient-centered care happen. And I think the solution is conversations about the common purpose, trust and respect for each other's professions and ways of working. And that's the only way to really solve that problem.
Brilliant. Jamie, no pressure.
So I think to build on Udi's point, and I guess from more of a technologist angle, I think patient-centered care, it's about the data. It's about getting the data into the right place at the right time to empower the clinician, the patient, be that sharing it nationally or sharing it locally. I think getting that data into the right place and being open with that data between organisations is probably a fundamental point.
And final thought, Murray?
So I'm going to end by opening a whole can of worms, which we haven't touched on, in talking about the NHS app, because I think the NHS app is a great opportunity for us. Again, if we believe this is a bit of a journey, the way it's been designed is as a repository for all this information. So you should be able to go into it and see your COVID passport, but also your GP record, your medication, your hospital record, your social care record, that will all come. So I think I do think we kind of need to get behind the concept of the NHS app, because that is something that is a kind of national thing, yes, but that you can localize. So you can surface, local stuff within it because of the way it's been designed. And I think that's a really good opportunity that we should all get behind as a kind of, future optimistic thing.
Brilliant. Thank you for your optimism through all of this. Right, big thank you to all of you on the panel. Thank you so much for all of that. And thanks to everyone in the room and who's been here online. I think we've gone all over the place in that conversation. It's inevitable in a kind of big, complicated topic like this, but I hope that's been interesting and useful, and everybody's welcome to stay and chat now. So we'll wrap up at that. Thanks very much, everyone.